Cathy Wicklund, who is a genetic counselor. She graduated from Texas and did work there for a while. Now she's the director of Northwestern Graduate Program in Genetic Counseling. Cathy has been a president also of the National Society of Genetic Counselors, and she has represented the organization at several national committees, including the Secretary's Advisory Committee on Genetics, Health and Society, and she's a member of the Institute of Medicine Roundtable on Transitioning Genomic Medicine Research for Health. She's also active on a state level, working with the Illinois Department of Public Health on genetics education and finance and reimbursement issues, and as a member of the Genetic and Metabolic Diseases Advisory Committee. Her research interests include cross-cultural communication, psychosocial and counseling issues, prenatal diagnosis, decision-making, billing, and reimbursement and delivery of genetic services, which are also so very critical. And she is going to be enlightening us with the topic about the role of genetic counseling in the age of genomics. Please join me in welcoming Cathy.
Thank you. Wow, you guys ready for enlightenment? You ready? All right. Well, first of all, let me also take you away from newborn screening a little bit. We're going to go back to that, I promise. But I'm going to take you to some sequencing issues. And I was asked to talk about exome sequencing in particular, but I really kind of want to focus a little bit more broadly on counseling for sequencing in general, whether it's genome or exome sequencing. But before we go there, there we go. Okay. I want to give you a little bit of my philosophy and wearing my hat as a program director of a graduate program in genetic counseling. And the way I view what I'm trying to do with my graduate students is to try to teach them the overarching skill set that I think a genetic counselor needs to have. You know, I think about the overarching skills that we have as an umbrella, and under that umbrella are the different specialties that we're going to be working in. There is absolutely no way that I, as a program director, am I going to be able to send my student out to every single clinical setting, every single clinical specialty, or even to know what the specialties that we're going to have to walk into as we progress in the future. So the way I try to think about it is like, what are the essential skills that they have to know so they can apply it to each specialty and to each setting. When I think about my curriculum, I try to minimize the thought that I'm going to learn right now about about prenatal genetic counseling versus cancer genetic counseling versus pediatric genetic counseling. There might be different content areas, but when it comes to actually planning curriculum, I try not to segment those as much because, again, they have to think, I can apply this set of skills regardless of what that specialty is. As far as content goes, you do have to think about what's new that maybe isn't in my content. So with sequencing, you know, obvious. You have to think about, am I teaching them about sequencing? You know, what do they need to know about that molecular technology? Are there maybe bioinformatics that might be different now that we're talking about sequencing that they maybe didn't need to know? Do they have the up-to-date resources to be able to interpret the variants? We have, you know, thinking back, we interpret variants of unknown significance. The difference, obviously, is there's a lot more of them, and we need to be up-to-date on the resources that we have to do that. So looking at our core counseling skills, just to review this, and this is kind of a compilation between some of NSGC's work that they've done and also our ABGC competencies: genetics expertise and analysis, ability to communicate complex information in a simple, relevant way for a broad range of audiences, interpersonal, psychosocial, and counseling skills, facilitating decision-making, and I really want to emphasize that this is an active process, not a passive process, and will become more important. Ability to dissect and analyze a complex problem, research skills, and knowledge of the healthcare delivery. So these are the core skills that we bring to these counseling settings. We've done this before. We've adapted to new technology before. Whenever something new happens, and I think about, as I'm sitting there listening, the first thing I think is, how am I going to explain this? How am I going to talk to this about my patients or different clients that come through my door? And we do this over and over and over again. We talked about karyotypes. We went into single gene testing. We then had to explain FISH. We went into microarray, gene panels, and now we're into genome and exome sequencing. Sure, in single gene testing, we were able maybe to sit down and talk about specifically what we were going to test for, the specific disorder itself. But in a microarray, I'm not sure I know any counselor who can really sit there and talk about every single possible thing that we can pick up from a microarray. And when I'm offering prenatal expanded carrier screening for 100 different disorders, I am certainly not going through that list of 100 different disorders with the person sitting across from me. So I think what we do is we evolve and we adapt to the new technology and the new testing options that we have. So I have to put this slide up here because if anybody was at ACMG a couple years ago, this just real quickly is Stanford and Informed Medical Decision Experience about sequencing. And basically what Stanford was doing whole genome sequencing on some of the faculty members at Stanford. They contracted with Informed Medical Decisions with a telephone-based counseling service. And Amber, I borrowed this slide, and they were talking about there was no protocol for which they could follow, but they came up with this protocol. And I ask you to look at this carefully, and if you're a genetic counselor, the first thing that struck me was, well, that looks like a genetic counseling session to me. There's really nothing on here that I don't do in a typical genetic counseling session. So again, I think we have to think about the fact that this is what we do. And you can substitute this whole genome sequencing for any other test or any other thing that we're going to be offering people. This is also from the same talk that Amber gave, and none of these concepts are necessarily new. Interpretation may change over time. The idea about recontacting patients, that is a debate we've had over and over again. There's certainly variants of unknown significance, and again, it's the amount of variants of unknown significance that might be different. We talk about benefits and limitations of different testing, and the general approach that she has at the bottom is avoid overwhelming with information. Learn prior experience and expectations and remain centered on that starting point. Again, this is what we're supposed to be doing in all of our counseling sessions. So I just want to back up a second because we are dealing with more information and just remind us again of some of the things that we have to remember about us as people, as individuals. So first of all, informed consent. Two major components, comprehension and free consent. But let's also remember that too much information can lead some decision makers to conclude that they're not capable of making an important medical decision, thereby relegating the decision to a doctor or a non-medical person. And certainly in a cultural perspective, this can happen anyway, regardless of the number of facts that you're giving somebody. But we have to be very aware of this. The more information we have doesn't mean that we necessarily then translate that on to the person sitting across from us. This also, let's talk about health literacy just for a second, because again, I think we have to remember we're dealing with the population. We as individuals, have sometimes limited ability to make medical decisions. So approximately 90 million Americans have low health literacy. That hasn't changed just because we have a more complicated test to explain. I love this slide. I borrowed this slide from Stephen Eck, who's in the pharmaceutical industry and does pharmacogenetics. And this just basically illustrates the fact that here on the y-axis is the number of facts, the hypothetical number of facts potentially relevant in making a decision. And at the bottom, you have our human cognitive limit. You see the red arrow about how many factors we can actually take into account in making a decision. And this is, you see the years here on the x-axis going up. You notice the human cognitive limit is not going up along with the number of facts. So just because we have that much more information doesn't make it that we can actually take all of that into account and make a good decision, or whatever a good decision is. Okay, so the things that I think about and what we absolutely have to continue to emphasize, it's not so much different or new, is the contracting piece. This piece about really getting to know the person sitting across from you. We can do study after study about what people prefer, and it's not that I don't think we should do that. And what do we find? We always find that people have different preferences. They have different needs and they have different wants from testing. So we keep doing this, we keep finding it, which keeps telling me that this part is really important, to sit and pay attention to what your patient or your client is telling you. It's our responsibility to filter that information. Our job is not to do an information dump on somebody and then ask them what they want to do. Based on what they're telling us, we really need to think critically about what information needs to be given. Facilitating decision making. Doing that is not, again, a dump and then saying, well, gee, what do you think and what do you want to do? That's not facilitating decision making. It's a much more active process. It's illustrating the paths that people have to choose from and the implications of each path. It's taking them down those paths. It's reflecting, it's redirecting. There's a lot of literature out there on how to help people make decisions, how to help clarify their values, and it does take some time, but this piece, I think, is going to be critical when you're helping someone decide about whether or not they want to pursue, in particular, exome or genome sequencing. But again, this isn't new. This is what we try to do when people come and see us. The psychosocial issues are still there. We're still dealing with ambiguity of risk, the burden of knowledge. These aren't new issues either that we've been dealing with. I think some of the things that we need to think about when it comes to exome and genome sequencing is really, before you offer the sequencing, who are you actually going to offer it to? I've been making some kind of calls this last couple of weeks in preparation for this talk to just kind of see what people are doing that are offering this in the clinic, not in a research setting. And I'm amazed kind of at the lack of consensus or the lack of discussion about a lot of these questions before they start offering it. It's kind of like, well, we can do this, so let's just do it. And then they're kind of stuck with the results afterwards, not quite sure what to do with all of them. So who are you going to offer it to? What lab are you going to use? Right now, people are shopping around. It's really interesting how people are sending things to different laboratories. They're shopping based on the quality of interpretation. How are you going to deal with the ACMG recommendations for reporting incidental findings? How are you going to handle interpretation? Who's going to do that for you if you get a list of variants back? Now, that could change post-ACMG recommendation guidelines, but you still need to think about those. And how are you going to handle the post-test counseling? Pre-test, what I'm hearing from people is that it's not really lengthening the pre-test counseling as much. And again, that's telling me that we're adapting and we're adapting our skills. But how are we going to give those results back? Is it going to be just phenotype-driven results back at the time of the first session, all of the results at once, or are there going to be subsequent sessions or even times in the life cycle that you're going to think about returning results? We need a sustainable model. If anybody remembers David Dimmick when he first started doing this at Children's, there were pre-test counseling sessions that not 6 to 8 hours at once. I think we would all agree that's a little too much, but 6 to 8 hours over extended period of time. This is not a model that we can sustain. So we can't do that. We need to think about the length of time needed for interpretation. I think the biggest burden that's falling on clinics that are doing this is after you get your results back. Days and hours that you're spending trying to sift through the results. And this again is something that we have to think about, the amount of resources that we have. And that also can limit access for other people to get appointments because you're spending so much time interpreting these results. Do you have the infrastructure? Do you have the resources to do all of this? And a big issue that limits access is the billing and reimbursement. And I think, Mike, you might have mentioned earlier, we're getting a little bit more attention from CMS. These are huge issues. Genetic counselors are not able to bill independently for their services. But beyond that, whoever is providing these genetic counseling services, we get terrible reimbursement for time spent with people. So it's a huge issue. And we don't get any time spent on the interpretation that it takes, which is another issue that laboratories and clinics are facing. So when you're thinking about what is the utility of doing this, what is the clinical utility? Where does personal utility fall into this decision making? What is our responsibility as clinicians? I think we do have a responsibility as clinicians to think about where this is being offered and what circumstances. What is the evidence? If we do implement this, we don't have a lot of good evidence that says that it's going to actually do good or improve outcomes in the long run. So if we do this, we really need to be collecting data over time to help us answer these questions. And what is the cost? One thing I hear a lot from people is they say, but it's cost effective. And the test is cheaper than doing a panel or multiple panels. That doesn't take into account any of the downstream costs. None of the interpretation costs, the time that you're spending, the downstream costs to the healthcare system as far as increased screening, maybe when we don't know for sure if that's something we need to do. So again, I just think we need to be critical about some of these issues as we move forward. What are the significant changes? All right, some people have said that we're dealing now with more of a genotype to phenotype. I would say, I would argue that no, that's not necessarily true. In an example prenatal setting, we always kind of assume a normal phenotype in a lot of ways, and we get a genotype, and we have to predict what that phenotype is, and decisions, critical decisions need to be made. Does it require different counseling skills? I'm going to say no. Is it going to change our counseling paradigm? We're not quite sure. Could it possibly be driven by technology and industry? I would say yes, a little bit. You know, I think that there's a rise of non-academic labs. It's an information age. People have a lot more access to information, and maybe moving this into clinic is faster now than it would have been 20 years ago. The amount of information absolutely has increased over time, and also the laboratories, what they offer, the interpretation, evolution of technology, is it more of the same? Probably so. Bruce Bloomberg reminded me when they were started doing karyotypes, it wasn't standard how many cells were being looked at. Laboratories were doing different things, and we lived through that as well. So, in summary, the way I view the genomic counseling world is that these are old issues that we've examined and we have talked about that are being exaggerated with sequencing. And it's really managing a complexity. It's pushing us to think and filter and be critical about the information that we're going to focus on and the information that we're going to leave out. And I'm going to end with my parting slide. This is the, I have broke every rule on this slide. This is bullet point number 1 on Ambry's consent form for exome sequencing. And I'm so sorry to anybody from Ambry. I have nothing against Ambry, but this just cracked me up. So, and you see down here at the lower left there is where your patient's supposed to initial, saying that they understand the technical limitations of the test. So, and I'm thinking to myself, really, you know, let's see here. You know, 90% coverage at 10x, leaving approximately 10% of the genome that's not being covered. Okay, so this is what I have to say about that. That's how I would counsel, and you know, this what we have to. This is the take-home message. It's the technology. We have always talked about the limits of the technology. It's not going to tell us everything. Thank you.